Hello, let's talk about breast cancer. I want to talk about the high yield material from this SDL before I dig into the weeds, so I'm going to start with my own slides. First off, breast cancer, how do you get it? Well, there are a few different cell types in the breast. What do we have? We've got adipocytes, a lot of fat there. We've got fibroblasts that make a stroma that hold everything together. And then we've got ducts, right? We've just got this branched, lobulated ductwork full of acini. Those are cul-de-sacs of secretory cells. We know what those look like because we've seen them in the pancreas, in the parotid gland, and any other secretory organ. So we've just got glands embedded in stroma and fat, and that's your breast. Well, where does breast cancer come from? 95% are adenocarcinomas, meaning they come from functional glandular epithelium, not from fat, not from fibroblasts. So the predisposing injury to breast cancer is going to be hyperplasia of that ductal epithelium. And that hyperplasia will turn into dysplasia eventually, when it picks up some deleterious mutations. And so that dysplasia is precancerous, and then it can just turn into full-blown cancer when it starts to invade outside the basement membrane. So there's hyperplasia of breast ductal and lobular cells that get the ball rolling on this. What makes functional cells of the breast grow? Good question. The answer to that is estrogen, because estrogen is going to stimulate enlargement of the breasts, period. It's a growth factor. And this also accounts for why certain breast cancers have the estrogen receptor on them, because estrogen just feeds them. It gives them food. It tells them to divide. So if a breast cancer has the estrogen receptor, that's really good news, because we can target it with something like tamoxifen, which is going to be an estrogen receptor blocker, essentially. And so we can shut down one growth pathway to inhibit the spread of that mass. So estrogen generates hyperplasia, and with enough time, hyperplasia becomes dysplasia, and there's your cancer. Now, breast cancer, how does it present? Age is a big deal. Over 9 out of 10 breast cancers pop up in women over the age of 45. Something else that's a big deal is palpation. Is it painful? Breast cancers are typically not painful to palpation. If it hurts, it's probably cystic change, fibroadenoma, something else other than breast cancer. If it doesn't hurt, then you're moving cancer a little farther up the differential. Another characteristic sign is going to be a nipple that's hard as a rock. And that hard, dense change, we're going to call a desmoplastic response. And that's evidenced by the gross section of this ductal carcinoma on the right-hand side of these two panels, described as stellate in shape with an irregular border. And on the left, that's what that looks like on mammography, which is just an X-ray. That stellate shape with a lot of wispy calcifications streaking off from it. And that's as textbook as it gets for an invasive ductal carcinoma. Now, that shape that you see on the left-hand side here, that's breast cancer. You can see other shapes on mammograms. And they'll calcify too, because a lot of calcium in the breast. They make milk. Milk has calcium. A lot of calcium there. A lot of fat too. Fat sequesters calcium. It's fat necrosis. Here we've got a fibroadenoma, which is a topic for a different SDL. I introduced this to show you that you can tell right away that's not breast cancer, really. That's circumscribed, very well circumscribed, It's at least not invasive. And right here, another well circumscribed, encapsulated lesion near the periphery. That's not breast cancer. Breast cancer starts typically in the terminal ductal units, kind of farther back in the breast. This right here, again, it's very well encapsulated. It's not growing along a duct. It's just a sphere. And so you would be more prone to say that's a fat cyst. That's some cystic change. I got a slide here on the HER2 receptor. We said that estrogen receptors make tumor cells grow in the breast. Well, so does this HER2 receptor. It's localized to the breast, and some cancers express it. It's a tyrosine kinase that forms a dimer and gets the mTOR pathway going, which is always associated with cell proliferation. And the name of the drug that we use to block this HER2 receptor and thus inhibit cancer growth is trastuzumab, the big complication of which being cardiotoxicity, which is reversible with withdrawal of that drug. I want to look at some histology now. So, big picture. You can chop up breast cancer into subcategories. First of all, you can say it's benign or malignant, which just means has it gone through the basement membrane or not? And secondarily, you can say, well, is it ductal or is it lobular? And so the difference between that is that you can picture the acini of these terminal lobular ductal units, TLDUs, and I'm just going to say TLDU from now on. You can picture them as cul-de-sacs. Have you ever lived in a cul-de-sac? I've lived in a cul-de-sac. I've lived in a couple. I like cul-de-sacs. They're cozy, you know, it's like you kind of feel like you're doing your own thing. So breast tissue has cul-de-sacs. And sometimes the cancer comes from the cul-de-sac, right? And so when the cancer comes from the cul-de-sac, we're really going to call that a lobular carcinoma. Now, when the cancer comes, not really from the cul-de-sac, but let's say you got some main roads out here, you know, when the cancer's coming from these main roads, that's when we're more prone to say that's a ductal cancer, because the cul-de-sac is the lobule or the acini of that glandular structure. And after the lobule secretes its product, which in the case of the breast is milk, where does that milk go? Well, it has to go into a networking system of ducts in order to reach the surface at the nipple. So if it's lobular in origin, we call it a lobular carcinoma. If the cell of origin is from one of these ducts, we call it a ductal carcinoma, and it is that easy. Histologically, you know you're looking at a ductal carcinoma if you see ducts. That's it. If you see a lot of lumens, you know that the cul-de-sac, you know, that's not a lumen. That's where we get our lobular cancers. There's no lumen in there. There's just a bunch of cells. So if these cells start expanding, they're going to create a solid mass that's not going to have any tunnel in the middle of it. But if these cells over here in the duct, if those start expanding, well, you will still have a lumen in the middle of that proliferating cancer, which is why you see lumens in ductal carcinomas, both benign and malignant. So looking at these images, we zoom in and it's like, oh, there's ducts everywhere in this John, right? Like there's a duct, there's a duct, there's a duct, there's a duct. There are so many ducts all up in this cancer that you know you're looking at a ductal carcinoma. And to add on top of that, you see that things are nice and sequestered here. They're not creeping into that stroma around it. There's still a basement membrane around these cancers. And so that's what would let you go a step farther to say this is a ductal carcinoma in situ, a benign neoplasm. Now, there's a variant of the ductal carcinoma called the comitocarcinoma, and that's one that you got to know it's in first aid. And the way that I've seen this presented in a question stem is as high-grade pleomorphic cells with central necrosis. And so it can also be a caseous necrosis. That just means that things die and they don't really get ate up by macrophages. And so you might even be able to get a little discharge out of the nipple in the setting of this comitocarcinoma. Now, when we say central necrosis, what we mean is that there is a duct here. There's clearly some sort of lumen right there in the middle. But instead of it being empty, there's necrotic cells inside that lumen that have sloughed off and are collecting within. That's characteristic for the comitocarcinoma. So again, normal ductal carcinoma, bunch of empty lumens all over the place. Comitocarcinoma also has lumens, but you see necrotic cells within those lumens. More examples here. Necrotic cells all up in the middle. There is clearly on the left here, clearly a lumen in the middle of these proliferating hyperplastic cancerous cells. But within that lumen, we see a bunch of crud, bunch of stuff, just cellular debris, carnage, That indicates the comitocarcinoma. Same thing here on the right. We've got proliferating, dysplastic, glandular cells, ductal cells. There are clearly some ducts here. You know that they're ducts because they've got lumens, right? There's a lumen. There's a lumen. There's a lumen. But inside these lumens aren't empty. What do you see inside of them? Swaths of necrosis, especially in this one here. I mean, it's almost totally acellular. It's like you're seeing nothing but the remnants of cells that used to be alive. And they just, again, peeled off the ductal epithelium and found themselves in the middle of that lumen. And so they're plugging up the lumen now. There's a few lymphocytes maybe in there, but mostly, again, it's just debris. That's the comitocarcinoma. Here's the photo from the SDL. The gross appearance isn't particularly important. What you want to identify, again, is here is a big duct. How do you know it's a duct? Well, you can see this little crescent moon lumen in it, kind of like if you were looking at the left descending coronary artery, and it's like there's a big thrombus inside. This looks exactly the same. So there's a lumen there. But what's inside that lumen? Necrotic cells and debris. So the lumen tells you that it's ductal, not lobular, and the debris tells you it's that subtype of comitocarcinoma. Now let's look at lobular carcinoma in situ. You don't see any lumens in a lobular cancer. You just see these masses of cells. You could call them nests. I suppose if it got large enough, you could call them sheets, but you certainly don't see empty luminal spaces within the lobular carcinoma, be it benign or malignant. So here's this mass of tumor cells, and there's no lumen in the middle, like a donut with a donut hole. We saw that hole in the middle of the ductal carcinoma. We are not seeing any such lumen in this lobular carcinoma. So that's how we're telling them apart if push comes to shove. Same thing here. What do we have here? A bunch of blown up terminal TLDUs, right? There we go. TDLUs, one of those two. And there's no lumen in the middle. There's no donut hole in the donut. It's just, I don't know. What are those weird donuts called that are just filled with jelly, and there's no donut hole. I'm like, that's not a donut. That's a assorted pastry. So that's what we're looking at there. It doesn't have a lumen. Same thing on the right-hand side of this page, just nests of cells all clumped together with no lumen in the middle. And I've said that 20 times because I want you to understand that is the number one way that we're going to tell apart a ductal from a lobular carcinoma on histology, whether it's benign or malignant. And if it's malignant, all that really means is that it's gotten through the basement membrane, so it won't be as well circumscribed as you see here. Now, ductal carcinoma, I found it very tough to get some histology that really was particular to the ductal carcinoma. What I want you to know is that in your mind, breast cancer should be ductal carcinoma until proven otherwise. And really, it doesn't matter too much what it looks like histologically because we're treating these cancers based off of, do they have the estrogen receptor? We can block that. Do they have the progesterone receptor? We can agonize that because progesterone antagonizes estrogen. Do they have the HER2 tyrosine kinase growth factor receptor? We can block that. So that's how we're treating these things. We don't care if it's ductal or lobular, really. So ductal carcinoma, think ductal until proven otherwise. So how do you know otherwise? Well, let me show you. If it's a lobular carcinoma, you see single filing. And if they want you to spot this on a standardized test, they got to put it in a consumer, in a language that everyone can understand. So it's going to look something like this photo on the bottom right here, where it's just like, come on. Single file lines of cells. Very, very obviously. Very obviously. I mean, they're so single file, you might think you were looking at cardiac myocytes or something, So they're just lines of cells. Why are they single file? Because they've lost E-cadherin, which is a junctional protein, which keeps cells together. And so if you have a big clump of cells, they're glued together with something, and that something is E-cadherin and desmosomes and gap junctions, etc. So if you lose those connections, cells just fall apart and they unfold. And so when they do that, they just take up this linear pattern because they fill in wherever they can in the gaps in between stromal tissue. So that's your lobular carcinoma. Again, you don't have to know what the ductal carcinoma looks like. If you understand the lobular carcinoma shows you single filing every single time. And if they don't show you single filing, it's probably not a lobular carcinoma. Let me point out one other big deal, which is the lobular carcinoma tends to be bilateral. So there's a B in lobular. There's a B in bilateral. So this is going to be the cancer of the breast that shows up in both of them at the same time. Not so in ductal. There's no B in ductal, so it's going to be unilateral. I also want to point out lobular carcinomas, they're very far back there. You know, think about anterior, posterior. Well, the nipple is the most anterior structure in the breast. And so your terminal duct lobular units are going to be at the back of the breast, posteriorly, relatively. They're going to be farthest away from the nipple. And so these lobular carcinomas, because they start off, they originate deep in the breast, they're going to be the last cancer that you catch on a manual. You're going to have to use mammography to get these things. Versus a ductal carcinoma, well, that can spread up the major ductwork of the breast pretty easily. And so those tend to be palpable masses. Whereas the lobular carcinomas, again, they're so deep in there that you really can't palpate them. Some photos here, big stellate appearance. Ductal carcinoma until proven otherwise. Always going to say that, yo. Stellate appearance on gross. This white area is what we call the desmoplastic stroma. It's a fibroblastic response. And again, when you take into account all the lipids and calcium that are in the breast, you can understand how that tissue becomes kind of fibrotic and immobile and dense. And then here's a very low power histology. The irregular margins tell you that you're dealing with a malignant cancer, not a benign cancer. Here is ductal versus lobular. So ductal on the left and lobular on the right here. And kind of tough to tell apart. Ductal, again, it's ductal until proven otherwise. But in this case, what are we seeing? We're seeing lumens all over the place. There's a lumen, there's a lumen, there's a lumen, there's a lumen. It's Swiss cheese over here. And so if you're seeing a bunch of lumens, you're like, it can't be lobular, because you know lobular, first of all, if it's benign, it's just going to be a big blob of cells with no lumen. And if it's malignant, you're going to see single filings. So that's got to be a ductal. Now we get over to our lobular carcinoma on the right. So it's carcinoma, so it's popped through the basement membrane. And we're going to see single filing. And I want you to look and see if you can identify the single filing in this cross section of histology. And at first I thought that it was all around the duct here, but no, it's not, because you notice in the caption, the duct is uninvolved. And so where's the single filing? Here's some. Right there, straight line of cells. Here's some as well, right through here, straight line of cancerous cells. So again, they're losing their E-cadherin junctional connections, and as a result, they're just kind of filling in wherever they can, and that happens to be in a single file line. Here's Paget disease of the breast. And this is going to be a ductal cancer that spreads to the skin. Now, Paget disease is technically benign. So this is going to be encapsulated more or less. And the malignant version of Paget disease is called inflammatory carcinoma of the breast. And that's where you get your orange peel, pewter orange or whatever, texture to the outside of the breast. So dipping into first aid quickly to show you what that looks like here. This is the orange peel breast right here, and you see these little pop marks on it, or it's kind of like goosebumps almost. like the peel of an orange. And so the reason why it looks like this is because you've got cancer that's turned invasive. And so it's invaded into the lymphatic networks of the breast. And so then you get lymphedema in the exact same way. Same edema as if you had, 2+ pitting bilaterally lower extremities, that kind of edema. It's just swollen with fluid because the lymphatics aren't draining properly because cancer is plugging it up. And so this orange peel plugged up inflammatory carcinoma of the breast, which by the way is probably the most severe breast cancer with the worst prognosis. This is a direct result of Paget disease of the breast, which is why it's important to know about both. I think I just closed my, did I just close my, no, I didn't close my PowerPoint. So Paget disease of the breast, once you see it, you can't unsee it, and it's involving the nipple. And on histology, you've got these epithelial cells. Those are the cancerous cells, and you can tell that they're just kind of migrating upwards towards the epithelium. They're very, very close to the surface of the skin, and they're obviously generating some inflammation, which is why it looks like this. So what are our signs of inflammation? Well, there's rubor, which is redness, right? Which is a direct result of blood flow into the area, and vasodilation of arterioles, right? And then there's calor, that's heat, and same thing there, arteriolar vasodilation. More blood flow to the area, more heat. And then you're also going to get some swelling in the area, and that's tumor, and that's due to a venous vasodilation and an exudate of fluid through those venous channels. And so that's inflammation. That's why this is an inflammatory precursor. Now that's about all the slides that I got to show you. Let's get into this SDL. Okay, so we're understanding that the reason you get breast cancer is because you have some sort of hyperplasia of breast tissue. Why would you ever have hyperplasia of the breast? Because estrogen makes breast tissue grow and divide. So the more estrogen you have, and especially it's a lifetime exposure thing, the more likely you are to get breast cancer. So we see that breast cancer, we put the cutoff about right here. 5% of all breast cancers occur in women under 40 years old. That's a big deal. 5% of all breast cancers occur in women under 40 years old. So you're reading a question stem and a 30-year-old has a palpable mass. Well, number one, if it's painful, it's not breast cancer. That's not what they want you to think. Number two, if it's painless, you still got to be very, very suspicious of breast cancer because it is rare in that demographic. On the flip side of that, you have a woman that comes in, she's 60 years old, she had an abnormal mammogram for the first time, and she's got maybe she didn't have a mammogram, and she's got this one nipple on one side that feels like granite. That's breast cancer until proven otherwise. Most common in North America, can be hereditary due to BRCA1 and BRCA2. Very rarely, P53 gene. If you inherit that mutation, that's called Li-Fraumeni syndrome. Understand that BRCA1 does double-stranded DNA break repair. And if you're like me, you missed that question a couple exams ago, and so you'll never get it wrong for the rest of your life. You're going to know like the back of your fingernails that BRCA1 does double-stranded DNA break repair. And the ovaries, you can get ovarian cancers if you inherit this BRCA1 mutation, but the diseased allele shows variable penetrance, which means that just because you inherit a BRCA1 mutation does not mean that you will get any cancer at all. In fact, you could live your whole life and never get any of these cancers. That's variable penetrance. Just because you have the genotype does not mean you express the phenotype. One more time, understand BRCA1 double-stranded DNA break repair. You get breast and ovarian cancer. And if you're a guy, you're at a higher risk for prostate cancer. This is pretty important to me. BRCA1 familial breast cancers do not express hormone receptors. They are very commonly what we call triple negative, the three receptors that we care about: estrogen, progesterone, HER2 neu. So BRCA1 breast cancers very commonly are naked on the surface. They don't show any of those receptors. That means that we have a tough time targeting these things with biologics. Sporadic breast cancer, if you get it spontaneously, understand the majority of these risk factors are due to estrogen exposure. So everything's going to make sense. And if it's not related to estrogen, it's your run of the mill reactive oxygen species type deal with alcohol consumption, smoking, and obesity. So because of the estrogen correlation, if you've got a high risk of breast cancer, then you're also at a high risk for endometrial cancer, because remember, those are also very, very estrogen dependent. So most breast malignancies are adenocarcinomas. We talked about ductal versus lobular. The cul-de-sac, remember, lobular versus the road that connects to the main street. And you can call that main street the duct. And so that's the ductal carcinoma. The cell of origin is going to be along the main street rather than the cul-de-sac. And the TDLU is going to be the answer choice if they ask you where does this breast cancer start from. You've got an adenocarcinoma of the breast. Where did it start from? And the way that they would probably ask the question is they would show you this diagram right here on the top of this page in first aid. And if you're looking at this diagram, you know what I see? I see A, and I see B, and I see C, and I see D. And then maybe the fibroblastic stroma right here is going to be E. And so they're going to give you a patient who's got a breast pathology, and they're going to just give you a diagram of the breast and say, all right, where did this start? And so for breast cancer, understand we're saying that the terminal duct lobular unit is where, according to first aid, every single one of these cancers is starting from these adenocarcinomas. Now, very rarely you can get a fibroadenoma that is of stromal origin. You might get this benign intraductal papilloma, but those are the exceptions. Normal stellate desmoplastic breast cancer starts in the TDLU. Carcinoma in situ, again, is benign, and it's going to be small and confined, and you're not going to pick this up on a manual. You will see it on a screening mammography. Side note, we want to start screening mammograms at age 50. Now, that's according to the U.S. Preventative Services Task Force. The American Cancer Society says we want to start it at age 40, and there's a lot of clamor to be pushing that age up. But as of right now, for exams, you're going to say age 50 is when we start screening mammograms. And then you're going to screen every other year until the patient's about 70 or 75 or so. So benign cancers, we catch them on X-ray screening, and they have not penetrated the basement membrane. You can have a ductal benign cancer, in which case you're going to see ducts inside the tissue. Look at all these ducts in here. Look at this micropapillary pattern. That's one large duct in the middle. And then very rarely you'll see a solid pattern. You won't get asked about that. And then the comitocarcinoma is a variant of the ductal carcinoma in situ. Understand this comitocarcinoma. So it's got carcinoma in its name, but it's not malignant. It's still a benign cancer. It's still in this carcinoma in situ section. So it looks malignant. The cells have a high degree of atypia, but it has not penetrated the basement membrane. So this comitocarcinoma is technically a benign neoplasia, albeit very high grade. And again, this dude likes to calcify, which is what helps us catch it on X-ray. And so calcification is going to add to the fibrotic nature of these cancers within the breast. Calcification likes to complex with lipids. It's called saponification. You can see some fat necrosis right there. So, and if you see calcification under a microscope, remember it's the color blue. Non-palpable, very rarely bilateral. When we see bilateral, we're thinking lobular. There's a B in lobular. There's a B in bilateral. And again, if it's in situ, that means we are probably not palpating it. We are probably catching it on X-ray mammography. These lobular carcinomas come from the cul-de-sac. And so they're going to be solid groups of cells without a lumen in the middle. And that's exactly what we see right here in this histology. Solid groups of cells without any lumens in the middle of the groups of these cells. There's no palpable mass, and bilaterality is most common in the lobular cancers. Now, we call breast cancer invasive when it decides it's going to leave home and penetrate the basement membrane with the type 4 collagenase and start to spread locally. The most common type of invasive carcinoma is invasive ductal carcinoma. And that's going to account for about 3 in 4 breast cancers, invasive breast cancers. So ductal carcinoma until proven otherwise. Got it. And there are several subtypes, but really what you get shown on the exam is going to be like Sway Lee. It's not going to have no type. It'll be no special type. And you'll see that it's tough to cut. It's again serous. It's got this desmoplastic stromal response. That's mentioned 3 or 4 different times on pages 7 and 8 here. And so if they bring that up in the question stem, it's very, very hard when you palpate it. It feels like a marble. Ductal carcinoma until proven otherwise. That stellate shape, pretty characteristic. Lobular carcinomas, only 1 out of every 10 invasive breast cancers is lobular. So how do you recognize this? Number 1, bilaterality. Number 2, single filing. So we looked at single filing. Here's another good example. You can just trace them. They look like a string of beads, or maybe like, you know, when you were a kid way back and it was like Halloween or Valentine's Day and you walked in your 1st or 2nd grade classroom and there were Smarties on every desk. You know, they look like a roll of Smarties. And so they're single filed because of, one more time, loss of E-cadherin. Then we've got some various other subtypes, tubular carcinoma, not too important. The one you want to know is the medullary carcinoma. And you want to know it, I say, because it's in first aid. So first aid says you need to know it. And how you're going to tell the medullary carcinoma apart from all these other breast cancers is by this characteristic lymphocytic infiltrate. It's got a lot of lymphocytes up in there. So I think I've got a color photo of this one. Here it is on the right-hand side. Let's go look. So cancerous cells, I'll outline here in green. Again, this is an adenocarcinoma variant. And then in blue, I will outline some lymphocytes. We've got a big patch right there. These are smaller cells with denser nuclei. Again, we're talking about T cells and B cells. Those are your lymphocytes. The natural killer cell is also a lymphocyte. They're of lymphoid progenitor origin, as opposed to your myeloid progenitors, which are going to go on to become macrophages and neutrophils and megakaryocytes, correct? So this big lymphoplastic, lymphocytic response in the stroma, the connective stroma of this tissue, is what defines a medullary carcinoma of the breast. And it's got a pretty bad prognosis. That's about all you need to know about it as far as I'm concerned. Molecular classification, and this is really how we group breast cancers in this day and age, is based on their surface receptor expressions. So if we have what's called a luminal A tumor, it's positive for both estrogen and progesterone receptors, and it's negative for the HER2 receptor. If we've got a luminal B tumor, it's only estrogen receptor positive. And then finally, if we've got a HER2 tumor, then it's expressing HER2, enough said. And then they also tend to be negative for estrogen and progesterone receptors. Finally, you can have a triple negative breast cancer that is more common amongst the Black population. And these are really unfavorable for prognosis because they're just tougher to treat. These receptors are our drug targets. So you take away the receptors and you got to get crafty if you're the oncologist. So I'll go through and reread this again. The luminal A tumors express Ki67, which is just it's a type of stain we can drop on these cells to tell them apart from one another. So Ki67 is going to tell you you're dealing with a luminal A or a luminal B tumor as opposed to a HER2 tumor. And then these HER2 tumors obviously will stain for HER2. I suppose that, you know, If you get told, all right, this cancer is estrogen receptor positive, but negative for the other two, what is it? And the answer choice might be luminal B. I could see that question being asked here on our in-house. Clinical presentation of breast cancer. Palpable mass if it's invasive. Again, if it's benign, you're not going to palpate that. You're going to find that on a screening mammogram. And the key word in the question stem is painless. If it's a painful mass, it's not breast cancer. Lymphatics might get involved if it's an inflammatory cancer, and that's going to lead to that orange peel lymphodematous appearance. The nipple can either be out and hard, or it can be inverted, pushed inwards. And so that's also a sign of breast cancer because there's so much fibrous tissue building up inside the breast that it's kind of pulling on that. You know, it's got a tensile strength, and so it's pulling that nipple inwards. Imaging, again, we're getting screening mammograms starting at age 50 every 2 years. And if one comes back positive, the very first thing you want to do is get a fine needle aspiration of that mass, similar to what you would do with thyroid masses. And then you look at the cells and you say, are they dysplastic? What are they stained for, etc. So on a mammogram, invasive cancer has this classic stellate shape. If it's a cyst of the breast, if it's a fibroadenoma, it is going to be a plain Jane oval or circle or sphere. It is not going to have these stellate, wispy, calcified protrusions. Paget disease of the breast, pretty rare, affects the nipple and the areola. These cancerous cells get very close to the skin. And again, this is a type of breast cancer. It is not breast cancer. So in words, we've got malignant intraepithelial adenocarcinoma cells. Those are called Paget cells. And you can tell them apart. They don't look like keratinocytes. So again, this is an adenocarcinoma that spreads to the skin. It can ulcerate. It can crust up. It can get very, very red. Pathology of the male breast. If a guy has breast cancer, play odds. It's BRCA2, not BRCA1. They'd never ask you that. Most of them tend to be invasive ductal carcinomas. They tend to be estrogen receptor positive. Then we talk about gynecomastia. Understand that gynecomastia is physiologically normal at 3 different points in the male life. Gynecomastia, if you see it in a little baby, it's totally cool. They don't have any endocrine problem. What happened was they were just in mom, and mom had really high estrogen levels. And so where did baby get blood from for all that time? From mom. So baby's got high circulating estrogen. Going back to the concept, why does the breast even grow to begin with? Because estrogen is there. For the breast to grow, estrogen has to be there. Another example of normal gynecomastia in males is going to be during puberty when you're making a ton of sex hormones. And so how do you make sex hormones? Well, you've got to get desmolase involved to make some, progesterone out of cholesterol, right? And then you've got to take that, or is it, no, it's pregnenolone. And then you take that and you modify it, and that pregnenolone is going to go, it can go down to aldosterone, remember, or you can run it through the 17-hydroxylase and then run it down and get some cortisol. And then you can run it even further and get your 17 ketosteroids, which are going to be like your DHEA and your androstenedione out of that. And so those are the common precursors to both testosterone and estrogen. So when you're making a lot of testosterone, because the precursors are there, you are also de facto making a lot of estrogen. So it's kind of normal if you see gynecomastia in a pubertal male. And then finally, the last point in life in which gynecomastia is really not that big of a deal is when you're an old dude and you just don't have it like you used to. You know, maybe your hair is starting to fall out. You're starting to get these blotchy spots. Maybe you've got like, I don't know. But and the moral of the story is that, you just don't have the same amount of testosterone floating around. And so your testosterone to estrogen ratio is a little bit out of whack. And so then gynecomastia can develop due to the excess relative estrogen in the body. So anything other than that is pathologic. And so what do we mean by pathologic? Well, okay, you're an alcoholic. You've got liver damage. Your liver metabolizes estrogens. You can't break down estrogens anymore, so you have high circulating estrogens. That's pathologic gynecomastia. Something else might be maybe you're taking a drug that's going to inhibit a particular enzyme in the steroid biosynthesis pathway. Maybe you're taking spironolactone, maybe you're taking ketoconazole, maybe you're taking cimetidine. Those are 3 different drugs right there that can lead to gynecomastia as a side effect. And Klinefelter syndrome, common chromosomal abnormality, that's going to be our XXY. And gynecomastia appears in 70% of patients affected with that chromosomal syndrome. Drug use, what kind of drug are we talking about here? Anabolics, anabolic steroids, precursors of steroids. A couple more medications related. HGH, again, anabolic. Maybe guy is taking exogenous estrogens. 5-alpha reductase inhibitors, there we go. So why would we give that? To get some size off that prostate, or maybe as a hair loss drug, right? Because DHT is responsible for male pattern baldness. So we give 5-alpha reductase inhibitor. Well, you've got a lot of testosterone now, and that can get converted to estrogen, whereas DHT cannot. So that's our breast cancer SDL. Thank you very much. See you next time.